been discussing. I think with this lecture, it's more of like how can we manage these TBI patients and then how we can work together in terms of managing these TBI patients. Right? So again, traumatic brain injury. So the definition is it's a non-degenerative, non-congenital insult to the brain from an external mechanical force leading to permanent or temporary impairment of cognitive, physical, and psychosocial functions with an associated diminished or altered state of consciousness. So next slide, please. There are different classifications of TBI. So there's based on severity, mild, moderate, and severe, based on occurrence, if it's primary or secondary, and then based on location, if it's focal or diffuse. So severity of, next slide, please. So in mild TBI, so you will be seeing this probably in the charts in the HNPs. I've seen there are some trauma surgeons who are more specific with it. There are some who are not. But, like usually in mild TBI, duration of loss of consciousness is less than 30 minutes. Post-traumatic amnesia is less than an hour. And the GCS score is 13 to 15. Ideally, with these trauma patients, they should be putting in the GCS score. But sometimes we don't see it, unfortunately. So, Now, for post-traumatic amnesia, I think speech therapy is, do you also do the grading, once it's appropriate, like a GOAT score?
We do. A lot of times, we're not doing necessarily those specifically. I would say ours is pretty more subjective, but we're open to ideas if you want something that's more.
Okay, sure, yeah.
Because a lot of times we'll do like the mini mental, or we'll do the slums, kind of to do a cognitive scale. But once they're alert and able to participate in that.
Yeah. All right. Yeah. Because there are definitely different scales. So I think we can work on doing something with screen forms, so that will also help with communication, classification and communication. So that's in mild TBI. So moderate TBI, duration of loss of consciousness is less than 24 hours. PTA or post-traumatic amnesia is 1 to 7 days. GCS score is 9 to 12. And then in severe TBI, so loss of consciousness greater than 24 hours, PTA is greater than 7 days, and GCS score is less than or equal to 8. So these behavioral complications, usually we see them in your moderate to severe TBI patients. Okay, so next slide, please. Another classification is if it's primary or secondary injury. So you'll see in the chart. So patient has cerebral contusion, vascular injury, lacerations. But even if after the initial insult, there's still something that's happening at the cellular level. So there's excitatory neurotransmitter release, free radical damage, metabolic derangements, ischemia. So these can still lead to this is still part of the complications of TBI. And then next slide. So another classification will be based on location, whether it's focal or diffuse. So again, you will see on the imaging, there's hemorrhage, and then sometimes if it's like a diffuse axonal injury, you won't see it on imaging. So again, because of the secondary injury, it's because of those secondary insults. Okay, so that's one way of classifying TBI. All right, so let's now go on to pathophysiology. The next slide, please. So contra injury. So it's when the brain strikes the skull in the site of the impact. But remember, so on impact, it's still bathed in liquid. So then the brain still strikes the skull on the opposite side of impact. So you may see that on some of the documentation in the chart. And then again, what's happening at the cellular level. There's axon shearing. So there's a normal axon, and then with impact, so it causes the axon to twist and tear, and you can see that there's permanent death of some brain cells. Okay, next slide, please. So symptoms, as you can see, it causes a lot of symptoms. So depending on what area of the brain was affected, but again, it's not just because of a certain location in the brain, because again, let's remember there's some other cellular activities are going on. So again, usually with frontal lobe injuries, you have this judgment, planning, concentration, issues with judgment, planning, concentration, and then memory, speech, auditory, and visual perception. So normally with these types of injuries, your frontal temporal lobe injuries, yeah, that's where you would see most of your behavioral injuries, behavioral impairments. Next slide, please. So what are these behavioral impairments? There's agitation, aggression, disinhibition, restlessness, impulsivity, inattention, emotional lability. So if you have these types of patients, it's hard for them to get to participate in your therapy, right? So anyway, let's focus more on like agitation and aggression. So agitation, usually this occurs in absence of physical, medical, or psychiatric causes. So it's why it's important to work with the physicians in terms of ruling out, is this just, is this really agitation, or are there other medical issues going on? So it's characterized by excessive behaviors, including aggression, akathisia, disinhibition, and emotional lability. So aggression, on the other hand, is your complex behavior composed of sensory, emotional, cognitive, and motor elements, which includes behaviors that are damaging to individuals or property, attitudes, moods, or gestures that people find threatening or intimidating. We've had this type of patient, right? So like nurses were just saying, well, he acts like a child, but that's your typical TBI patient. So and then there's purposeful behavior. That's fine, and we can move on. So why should we discuss why should we discuss these behavioral impairments? So studies have shown that 70% of patients with TBI will present with some sort of behavioral problem, and agitation can be seen at least 40%, and then aggression at least 30%. So expect those ones we see are moderate to severe TBI patients. So next slide, please. Again, as you've seen, as we have experienced, they can have varied impacts on outcomes, therapeutic interventions, safety concerns. So, we can be hit by these patients, right? So, and of course, discharge planning is hard, to plan disposition for these types of patients if we're not controlling these behavioral impairments. Okay, next slide, please. So again, we should understand why these behaviors occur. So again, it's damage to specific brain regions, post-traumatic amnesia, impaired communication, and it's a method to control their environment. Okay, so let's go into this into detail. Again, your frontal cortex, your limbic system, your temporal lobe, those are usually impaired, so it increase in behaviors. This is a picture of Phineas Gage, and like in science, is one of the most popular neuroscience patients where he was hit by this rod, and then he had a very different personality after the injury. So they had more studies about TBI and personality behavioral impairments after this patient. So again, as we can see, it's not just because of certain lesions in the brain. There's also a combination of the lesions and the dysfunction in the neurotransmitter system. So next slide, please. As you can see, there's that imbalance in dopamine and serotonin. So you would usually see these behavioral impairments. So that's where our medications become more relevant. Okay, so that's where we as physicians can work with you in terms of managing these medications for these behavioral impairments. All right. So next slide, please. So another cause of behavioral impairments would be your post-traumatic amnesia. So again, there are some scales to determine this. So what is it? It's a state following brain injury characterized by disorientation, impaired memory, and impaired new learning. So they're unable to regulate or understand the consequences of their behavior. So imagine, you're this patient, like all of a sudden you don't know where you are, and then someone you don't know tries to grab you and tries to like hold your hand or lift your legs or like how would you react to it? You don't know anything. You don't know what happened. So so that's why you would see these patients that are trying to hit you. Or some of them like become emotional because they don't understand what's going on. All right. Yeah. So next slide, please. And then impaired communication and method to control the environment. So some of these patients, how we work with stroke patients, right? Some of them when they're basic, so they start some of these TBI patients are like that. They're unable to communicate their needs. Like they want to go to the bathroom, but they can't communicate it, so they start acting out. So that's why some behaviors occur. And then again, method to control the environment. They use their behavior to avoid a task or a person. So the behavior might serve as a purpose of getting that person or the task to go away. Okay. And now, so how do we address it? So what should we do as a team for these patients? So again, first is consider the differentials, identify the unwanted behaviors, consider environmental issues and medication management. Next slide, please. So this where you can look at the chart, try to coordinate with a primary doctor, see what's going on, make sure is it just behavior or is there something medical going on? So again, look, are there metabolic disturbances? Could this possibly be an infection? Hypoxemia, PE, because again, with hypoxemic insults, again, it can be causing these behavioral impairments. Again, could a patient be having seizures or having hydrocephalus? Medications, so is there something in their medications where they're actually, causing some side effects? Or, these trauma patients, they're usually intoxicated. Is the patient going through a withdrawal? And did the patient have history of psychiatric disorders, mood disorders, or is this actually delirium? So that's where we'll need to work with the primary team, or we can work together in terms of determining this behavioral. And so next slide, please. So again, how do you identify this unwanted behavior? So I also had this lecture with nursing. So and then we're trying to coordinate with trauma in terms of having these scales. So the Rancho's Los Amigos scale. So this represents a typical sequential progression of recovery in TBI. So we use that in rehab. So usually the Rancho's Los Amigos. So where you have your the four. Next slide, please. I think it's over there. So you have your confused and inappropriate response. So confused, agitated response. Usually those are those patients who have the behavioral impairments. Okay. And then next slide. So the agitated behavior scale. That's the criteria that's being used. And then again, this is something that we may work with nursing or in the primary team in terms of putting in these scales so that we have an idea on if this is really agitation or if it's if it's like something else like medical. Okay, and then next slide, please. So that's the scoring. But I think this will be more relevant for nursing and primary team. Okay, and the next slide, please. So here, environmental issues. So reorientation, addressing the triggers, making sure we have a low stimulation environment, and then with use of restraints, we should also consider that in terms of how we use these restraints, redirection, and then having a behavior plan. So we can discuss this in more detail. Next slide, please. So again, reorientation. So remember, like these patients who have post-traumatic amnesia. So that's where we come in. Tell the patient, reorient the patient. This is the time of the day. This is what this is where you are right now, and then making sure that there's a clock, there's calendar, so that you're oriented to the dates, the time, and then with our TBI patients, we encourage them to we encourage family to post pictures of how they were before the accident, because that helps remind them, and again that helps with reorientation. So because once they understand, this is what's happening, then they feel more safe. There's less of that acting out. Okay, and the next slide, please. So addressing triggers. So again, some of these patients can't communicate, so we should be more proactive in addressing these triggers, looking at what may be causing these behaviors. So again, addressing the pain. So if we're noticing that again, these patients may come in with a lot of fractures, right? They're trauma patients. So again, working with the physicians in terms of titrating these medications or maximizing the modalities. And then again, time toileting program, making sure that they're it's not they're acting out not because they just want to go to the bathroom. So if we're doing that, then at least we're preventing acting out from not being able to communicate that they actually have needs. And regulating sleep wake patterns. So fatigue studies have shown that if this is disrupted, so again that causes issues with recovery in TBI patients. And and considering that, then also with the breaks that you have to structure breaks in the patient's day. So when you're putting in like scheduling, so making sure that as a team we should coordinate in terms of making sure that it's distributed all throughout the day in terms of their therapies. And then again, we have a lot of elderly patients, so assistive devices, hearing aids, making sure that they have it, telling family members to bring in those assistive devices. Again, and then low stimulation environment. So it's better for patients if the TBI patients if they have a low stimulation environment. So we want to minimize noise. So we usually tell nurses like make sure that these patients are in rooms that are a little bit farther from the nurses station, and then making sure doors are closed. Pull down the blinds at night because in the morning it's still be up. It's still part of that reorientation. Blinds up during the day, and then limiting the number of visitors. So this is like one study where you were actually working with TBI patients, and part of the low stimulation environment they were wearing these special bulbs so that all lights are off except for those lights that the physician or the clinical staff is carrying. Okay, so next slide, please. And so guidelines for communicating with TBI patients. So use social greetings. So these are cues for them to relax. So speak calmly, slowly, briefly, clearly, and directly. And some of them will, will keep on perseverating on certain things. So, so instead of disagreeing, make a neutral statement or redirect attention to another topic. So when you say redirection, so it's like an abrupt change of that topic. So it sounds rude, but TBI patients respond to it. And then provide patients with a choice instead of a command. And then give patients ample time to process information and formulate their responses. We have to be patient with these TBI patients. And then formally end the interaction as patient may not be aware of normal social cues. Okay. Next slide, please. So, and then explain what you're going to do before you do it. So vitals, procedure, before starting the therapy. Keep it simple, provide clear and specific explanations of expectations and directions. Patients don't appreciate it if you're not all of a sudden you grab them or touch them. So definitely avoid that. Always approach the patient from the front. Do not crowd the patient. Break down difficult tasks into small steps. They're like they easily get frustrated. And again, as we mentioned, redirection. So the blatant and drastic change of topic or change of activity. Like for example, a patient you're just walking with a patient and then they keep perseverating. I need to go to the bathroom. I need to go to the bathroom. Or and then as you get to know the patient, let's say for example they like a certain team, so just bring it up. So that I heard you like this team, and then so you start another topic for them, and then you stop perseverating on certain things. Okay, so next slide, please. So again, behavior plan, positive reinforcement. So some of these patients, they will refuse to participate. So try to get to know them. Like, what do they like? So, and I think we've done that in rehab. Like if they like a certain show, or I think we have those, for example, to get them to ambulate. At the end of the call, there's actually like a reward for them. There's a positive reinforcement, or we've had therapists where they have like a show, on a computer at the end of the call. So like once they've completed that, then they can watch the show. And then negative reinforcement is just the opposite. So you take away the activity based on the specific behavior, and differential reinforcement is basically combination of these strategies. So next slide, please. use of restraints. I will discuss this with nursing. So as much as possible, minimize it. Utilize non-contact restraints as much as possible. Well, you have the posty bed there, and then the vests. And as you can see, as much as possible, we discourage like the type of restraints where it really minimizes their ability to move around. I mean, so at least like if you tie up your hands, they get more agitated. So again, you wanted freedom of movement, but then you still want it to be safe. So again, it's a matter of choosing the different types of restraints. I think they're still talking about this with administration. What should we use, what should we acquire. So we're still in that process. So medication management. So this is where we would come in. First would be discontinuing medications. Looking at what should be discontinued, because again, some of these can amplify agitation. Or narcotics, or benzos, dopamine agonist, H2 receptor antagonist, or anticholinergic medications. So I think this is where like with the consults, like I can coordinate with the primary team in terms of what should we do about your medications. Okay, and then next slide please. So you have your antipsychotics. So this is usually not recommended as long-term agents, but then if safety is compromised, so that's where we give Haldol, Riperidol, which are given IM or IV. And then next slide please. So other atypical ones, these are the ones that have more evidence in terms of TBI patients because they have better side effect profiles. So your thiopin or your risperidone. Some examples. Next slide please. Your anxiolytics, your benzos. Usually it's for rapid resolution. So if you have really violent agitation, so your benzos can be used, and lorazepam is usually what we use because there's less of those side effects, such as cardiovascular and respiratory side effects, right? And then next slide. So neurostimulants. So it seems like it's contrary, but again, these patients will have those cognitive issues, memory issues. So that's why we give amantadine. So it's both effective based on studies for acute and chronic TBI agitation because it improves attention, concentration, processing time, initiation, orientation, and sequencing, verbalization, and participation. So normally its effects are seen after several days. Okay, so next slide, please. So some side effects to worry about. So this is where again, we work with the patient in terms of balancing out, the benefits of these medications versus the side effects. Okay, and the next slide. So again, methylphenidate is another neurostimulant. So it also improves cognition similarly to amantadine, and it's more benign side effect profile. Next slide, please. So there's bromocriptine, dextroamphetamine, which is, but then more popular with your amantadine and methylphenidate. Okay, next slide, please. So this also has propranolol has the best evidence for efficacy in treating post-traumatic agitation, and so it improves restlessness and disinhibition, and also for treating hyperadrenergic state, your dysautonomia. Your severe TBI patients, like patients will say, oh, they have high blood pressure, high heart rate, their respiratory rate. So again, it's this a dysautonomic state. So I think I've recommended that in one of my consults for one of the TBI patients. So next slide, please. Anticonvulsants. So you have your valproic acid, your carbamazepine. Again, we have to monitor in terms of hepatotoxicity, thrombocytopenia, and then also with carbamazepine. Okay. And then there's gabapentin, lamotrigine, and phenytoin. But again, these would have a negative cognitive impact, so usually they're not first line for these types of patients. So next slide. So your antidepressants, again, used for behavioral symptoms, and again, your trazodone, they're also helpful for regulating your sleep-wake cycle. And you also have your sertraline, fluoxetine, paroxetine, and citalopram. Okay, next slide, please. amitriptyline is another one with again, anticholinergic effects, QTC prolongation, or what we would worry about for and potentially lowering the seizure threshold for these types of patients. So this is a slide. The next slide, please. Basically, I think it's more useful like for nursing where I've discussed this, what would be the first steps. And I think, this is at least you'll know like when, what medications were given, how severe those TBI patients are. And then, if they have other concerns, other medical issues, then there are more appropriate drugs for it. So this is just more of like an algorithm that we follow. Okay. And then next slide, please. Basically, if they have elevated blood pressure, we consider propranolol more. If the agitation is episodic, so you have your anticonvulsants, and then if there's also emotional lability, then we add, your antidepressants, and then if there's insomnia and pain, so we also consider tricyclic antidepressants. Okay, I think that's the last one. But I think what's more relevant would be, the behavioral interventions, which I've mentioned earlier. Any questions or concerns?
Among the staff, like in the team, who will grade the RLA? Who will determine that? You or the
Grade the
trauma,
what?
the RLA, the ROS?
Ranchos Los Amigos
Who will do
scale.
that?
Usually we do that in rehabilitation, but I think like for nursing, we're going to teach the agitation behavior scale.
It's the nursing that will.
And in my experience, I don't know if you like would do it like speech also like documents it.
Right.
So
And then we're happy to start using the GOAT more consistently, if that's what everybody would prefer for.
yeah, or we can work
Yeah,
together like
absolutely.
what works for the system.
And so
it's
we're not always getting consulted on TBIs,
Mhm.
which is another thing that we need to maybe make
Yes.
sure that we're not missing out on those, and then we can be more consistent with that.
Okay, yeah. So I guess anyone who has like any brain insult. Yeah,
It would be
make sure
nice,
that
yeah.
speech
We-
is
Sometimes we
yeah,
may forget
involved.
us occasionally.
Or like I understand like sometimes I get those consults and if I see that speech is not placed in, I can put it in. So I guess we can all work together as a team so that identifying all these medical needs so that we can make the primary team aware that I think there's some other medical issues that we need to address. Okay, this medical issues are interfering with therapies. So this is where we can all work as a team for these patients. Okay.
We do have an interesting patient now. If you've never heard of, I almost forgot the name. Lance Adams, yes. Lance Adams
Mhm.
syndrome, which is after an anoxic brain injury. And there's only like maybe 150 cases of
Yeah.
it because most people don't survive it, which is kind of an interesting. It's a
So
myoclonic disorder. It's like there's
Yeah.
there's these huge myoclonic.
So what
Nerves.
team who's the primary team in the patient?
She's just hospitalist, so she's already in placement at neuro.
Oh, okay.
So she's already there, but there's some concern for some increase, so I think they may pull neurology in.
Okay, all right.
Anyway, but
So
I know.
there's certain times when I think like we're here, making them aware that we're here. There's still something that we can help to address the problems that we can do to help address the problems with these
I
patients.
don't know, is that somebody that you would want to be consulted on?
Yeah.
Or since they already have placement, or are we good?
Yeah, I know like this hospital is just more familiar with post-acute care
Right,
placement
right.
and not just like physical medicine rehab. So sure, I think we tell the doctors, but then sometimes they still forget,
Okay.
or some of them, they just want the admission to be quick.
Right,
You know,
and then
just
go back where they
yeah,
were. Okay.
yeah. But unfortunately, these patients still have outpatient needs,
Mhm.
or just identifying those needs. So
Or even
It's a-
medication management needs, because
Yeah.
I feel like she's worse than she was a month ago, and I don't know if it's because there's an underlying infection that has created more issues. But it's interesting and
Sure,
kind of something that I think it would be my first one, and if there's only like literally 150, probably the only one that we'll see.
yeah, again, like anything that interferes with function.
Okay.
Yeah.
Okay.
Yeah. we
I
definitely
think it's a continuous education and
Yeah.
reinforcement on the hospital's
yeah.
side to even maybe drive that referral to discussion.
Yeah.
Because when it doesn't go to her, it doesn't get filtered, and speech is forgotten, and
Right. And I don't know if it's just because they already have a placement, you know, I'm not
right.
if that's
But it still does not address the need while the patient is here.
correct, yes.
So the rehab need while the patient's
And that's why sometimes I see like I put in the order like that we can see as outpatient. So I think I think as a team we can also work in reinforcing that because as of now we can't address it as inpatient, but these patients have chronic complications or
Absolutely.
complications that will come up as outpatient. So definitely need to monitor those.
Well, that's good to know. I just never know how far to push with, or what to ask for that's appropriate, and so that's always great. Thank you.
maybe if that's something that comes up in IPOC and say, hey, has there been a consultation to Dr. Anna about this patient?
Okay.
Maybe just drive that in that direction too. Maybe they can initiate that process. Okay. Anybody else? Well, we thank you very much
Yes,
for
thank you.
for
Thank you.
for
Yeah.
coming in.
Wait a minute.